Drugs of abuse. And I'm not going to talk about just the drugs that we think of, but other things too that are less known or less paid attention to. So that's what we're going to do today. All right. So just some quick objectives. It's a familiarization. I want you to be able to identify these things. And yes, we are therapists. And yes, we don't do anything with as far as giving drugs or anything like that. But, you know, you will have clients. Some of you are working in substance abuse, or some of you are working in, you know, inpatient units. Some of you are addictions counselors, but we're all therapists or therapists to be. What happens is we have clients that come in. They may be having problems with things that we don't recognize or that weren't told to us in our education. So that's why it's important to go over these. So one of the big things is being able to recognize, if you have a client that you're working with, being able to recognize signs of withdrawals that can tell you that something's going on there. One of the big things I want you to know is that I want you to remember is that abused drugs and substances are not only the illicit ones, not only like the marijuana and the cocaine and all that. They're not necessarily the ones that are, you know, street drugs. So I want you to know that up front. Prescription drugs, because we've got such a big opioid crisis in the country, and prescription drugs for pain meds, and these are all legal drugs. These are all legal drugs for, you know, psych stuff and pain management, things like that. The abuse is going on the rise, partly because of finances, healthcare, things like that. So that, you know, that isn't helping. The thing about these drugs is the duration effect. You're going to see different things in different people. So it's not across the board how one thing's going to affect somebody, whether it's alcohol, whether it's, you know, hallucinogens, whether it's somebody abusing their psych meds, things like that, which is possible. So, it depends on the person. These are just some things about duration of effect. So don't think in terms of cookie cutter when you're getting people that come in. Next, look at these, and what you see is the things that we're used to seeing. What do you first think of when somebody says drugs of abuse or substances? This is what you first think of, right? So if you look, the picture on the on the left it's alcohol. Well, alcohol is legal. It's not illegal. People use alcohol. It's not illegal. Look at the one on the left. What do you see in there? What kind of things are mixed in the picture on the left?
Marijuana, jewel.
See a cigarette there?
Cigarette.
Okay. Yeah, you see some pills? Mm-hmm. Okay. So yeah, there's a lot of things there, isn't there? There are things that we immediately recognize as illicit, as they call it, but there are things there that we see and they're put in here with illicit drugs. However, they're not illegal either. Right? The cigarette, some of those pills could be for like medical conditions or psychiatric conditions like, ADD or bipolar disorder or something like that, or an anti-anxiety medication. So it's all mixed in. So you really don't know, but they're in there. And that's part of the problem. So when you think about drugs, I want you to think about anything could be misused or abused. Okay? Irene Yanez, cocaine has a medical use? Well, believe it or not, Coca-Cola used to have cocaine. It was used in the old days for like tooth pain and stuff like that. But people use it as a medicine when they self-medicate. That's part of the problem. Remember this picture. Remember, you're going to see things that, again, when people hear the word drugs and illicit drugs, drug abuse or substance use, the DSM now calls it substance use disorders because it's not necessarily abuse all the time, and they took into account people misusing their prescription medications. This act, anybody familiar with the schedules of controlled substances? What it was in 1970, the Controlled Substances Act was brought in. And what it does is breaks the different medications, not just illicit drugs, but medications as a whole, into schedules based on their risk factor, their probability of addiction, narcotic, substances like that. So an example that I have for you is doing my nursing. When we'd be on the unit, we have the medication room. And so if I'm giving medications and I have to give something like an opiate for pain, or like OxyContin, or I have to give like a Valium or Xanax to a patient who's anxious, things like that. These are actually medications that are nationally registered under a certain schedule because of their again, risk of addiction and safety. So as the nurse going in to get the medications, I had to have a special code to get in the first place. But if it was a narcotic-based medication and one of these schedules, I had to count it before I took it out of the drawer, and I had to make sure I only took what was, needed. And then I had to recount and then put in a number how many are left in the drawer. Because at the end of every shift, the oncoming nurse and the outgoing nurse that are giving medications have to count medications, and we have to count the narcotics in the locked drawers. And so if there's even one pill missing, which is I've seen happen, if there's even one pill missing of a narcotic medication, you are there all day looking for it. If you can't find it, you can't reconcile it on the medication cart, then all kinds of bad things happen. We have to do a report to the supervisors, to the hospital. In the VA's case, the VA police have to have a report. And so that nurse is, that pretty much like biting nails now because we can't find this medication. So there's a lot of safety around it. So that's why we have the schedules of these medications. And so if you have a client who comes in and you're doing therapy with them and you know that they're on, again, last time we talked about the importance of doing a medication history with them. It's not a HIPAA problem. I know somebody had asked that before. It's not a HIPAA problem. If they're giving you their medication information, they're giving you what they're on. And it's important for you, even though you're not the medical doctor, but you are, a healthcare provider. So you need to know what they're on. It's going to be prescription, but this way you'll know that, they take Valium, PRN, or as needed. Well, that's a Schedule 4, so probably not going to abuse it, even though there's potential for risk if they overuse it. You've seen the effects of Valium on people, they take too many, sedatives. Yeah, so morphine, okay? People that are on morphine for pain, that's a Schedule 2. But it's for medical reasons, pretty much. But people can get addicted to it because of the effects of it. It calms down the pain and all that. And if somebody's self-medicating, then we got a problem there. Ritalin is actually a derivative of meth. It's methylphenidate. So that could come under a schedule. And that is one of the prescription medications that is abused a lot by people trying to stay awake to study or things like that. Before I start with the big stuff, let's just get some definitions straight. So these are the main terms we use in substance use. The first one, of course, is addiction. That's the one we all know. And basically that is the person cannot function without whatever substance it is, regardless of what's happening to them. So we all know what addiction is. But then we get to these other words, and it's important to know the difference between them because it will guide your thoughts and your plan if somebody is going through one of these. There's addiction, then there's dependence. And if you see an addiction, it's the person has to use it regardless of if it hurts them or not. If you look out on the streets and you see like a homeless person and they've got a bottle with them or something, a lot of people who are homeless because of substances, and alcohol is a big one. A dependence, again, it's a psychological or physical need. They need it to function normally, so they're dependent on it, kind of like you're dependent on your car to get somewhere, something like that. So they're dependent on it. If they had to, if somebody had to take them off it or something for some reason, they wouldn't function well. And so that's when you get the people that are going through recovery. They don't function well until they get well into recovery, okay, because they're dependent on it. Intoxication is basically they're strung out. They're strung out, they're high, they're drunk. In the medical world, in the medical side, if someone comes into the ER intoxicated, the ER is supposed to get a blood alcohol level, and to be admitted to like one of my units, it had to be under a certain level, because if it was above a certain level, then they had to go like to the ICU or a medical floor to be medically detoxed. So if somebody's intoxicated, they are basically what you see out in the streets a lot. They're intoxicated, and you can be intoxicated on the drugs too. That's just the term intoxication, under the influence. Years ago in quite a few states, and I think there's more states that do it now, you could be pulled over and given a DUI if you were driving and you had just taken like a medication for allergies that makes you drowsy, or if you had taken a medication that was a prescription but you needed it. Let's say you have pain meds, right? Some people, they get Oxy, or they get the most common one, I just blanked on it, but the narcotic medication that the opiate. I had to go in once to the ER. I had a migraine, never had them before. Well, they gave me the medication, Vicodin, that's what it was. They gave me Vicodin for the pain. Well, since I was on the Vicodin, there was no way I was going to go to work because I would be under the influence. So be very careful yourself, but you also want to be able to educate your clients on this fact that even a regular medication, if it causes altered functioning and they're out doing something and something happens, they're considered under the influence, and the police will stop them on the road. Tolerance, it's basically tolerance. The same effect doesn't happen unless you have more. Your body just gets used to it, and your body's now saying, well, we need more of that because this isn't working. And so they get tolerant of it. So what happens is you get this kind of like a scaling up. They need more to get the same effect. And then what happens is they take more, they get the same effect, but they end up being intoxicated. And then over time, there comes a dependence and then the addiction. So it kind of moves up this ladder. And so you'll see people at different stages in their substance use. And again, not just for illicit drugs, but for any kind of medications. Withdrawals. Withdrawals are one of the things you may see in a client, whether you're in private practice, you work in an agency, you're doing street work, anything like that, community. One of the things that you're going to see is withdrawals, and you want to be able to recognize these people not having what they wanted to be on. They're having withdrawals, they're having those bad effects. And I've seen, if any of you have worked inpatient, I have seen some withdrawals. One example I'll never forget is in the middle of the night when I worked night shift, the ambulance came running in with their gurney and everything. A gentleman on the addiction unit was withdrawing from heroin, and the paranoia and just the hallucinations he was having and the DTs and everything. He tried digging his way out of the room to the outside behind the sink. He'd been digging with his nails, and his nails were all gone and everything, but he was really out of it. He wasn't on the drug, he was detoxing from it, but the withdrawals were so bad that he literally dug a hole in the cement, the plaster, in his room to get outside. So that's how bad they can be. A person can die, they can have seizures, with alcohol, things like that, but they can have heart effects. So you want to be really careful. If you have somebody that you're treating who is in recovery or has a substance use problem, or you're treating someone or you're working with somebody who is taking regular psych meds, but something is not right and they're misusing them, then you want to know, kind of what the withdrawals are. As far as biology, the neuroanatomy and the biology of all this stuff, I want to talk about the central nervous system real quick, because this is like your brain down to the first part of down your spine. And this is where everything happens. And when substances are used that are harmful to our central nervous system, a lot of bad things happen. So I have a video that I want you to watch. It's 9 minutes. It's a quick lesson on the central nervous system. I want to come at this a little bit from the biological side so that you understand what's happening in the brain and where things are and how these things would be affected by these substances when I talk about opiates in the CNS or sedatives in the CNS, CNS depression, CNS stimulants. How's this?
That's great.
Good?
The great and mighty nervous system, or the brain as most of us call it. What makes this organ unique is that within it lies the ability for humans to know oneself. This feature distinguishes and sets the human species apart from the rest of creation. This ability is known as consciousness or intelligence. To begin, let's look at the primary function of the nervous system. The basic purpose is to coordinate all of the activities of the body. It enables the body to respond and adapt to changes that occur both inside and outside the body. Now, the nervous system is actually split into two parts: the central nervous system and the peripheral nervous system. We'll explore the peripheral later, but first, let's look at the central nervous system. The central nervous system is made up of two major structures: the brain and the spinal cord. As most people know, the brain is found within the cranium or skull, and there are 6 main sections among other structures within it. These 6 sections are the cerebrum, cerebellum, diencephalon, the midbrain, pons, and the medulla oblongata. The first section is the cerebrum. This is the largest section. It's divided into 2 major hemispheres, which are the right and left hemisphere. And the cerebrum is further divided into 4 lobes. These 4 lobes are the frontal, the parietal, the temporal, and the occipital. The frontal lobe is primarily responsible for reasoning and thought. The parietal is primarily responsible for integrating sensory information. The temporal is primarily responsible for processing auditory information from the ears. And the occipital is primarily responsible for processing visual information from the eyes. The second section of the brain is the cerebellum. This is the section located in the back of the head, below the cerebrum, and above the first cervical of the neck. It is responsible for muscle coordination, balance, posture, and muscle tone. The diencephalon section is found between the cerebrum and the midbrain. It contains 2 structures, the thalamus and the hypothalamus. The thalamus behaves much like a relay station and directs sensory impulses to the cerebrum. And the hypothalamus controls and regulates autonomic nervous system functions such as temperature, appetite, water balance, sleep, and blood vessel constriction and dilation. The hypothalamus also plays a role in the emotions such as anger, fear, pleasure, pain, and affection. The midbrain section is located below the cerebrum at the top of the brainstem. It is responsible for certain eye and auditory reflexes. The pons is located below the midbrain and in the brainstem. It is responsible for certain reflex actions such as chewing, tasting, and saliva production. And the last section is the medulla oblongata. It's the lowest part of the brainstem, and it connects with the spinal cord and is responsible for regulating heart and blood vessel function, digestion, respiration, swallowing, coughing, sneezing, and blood pressure. It's also known as the center for respiration. Now that we've covered the brain, let's take a look at the other half of the central nervous system, the spinal cord. The spinal cord is the link between the brain and the nerves and the rest of the body. The spinal cord is divided into 4 different regions: the cervical, thoracic, lumbar, and the afferent and efferent spinal nerves, which merge to form the peripheral nerves. The afferent spinal nerves are responsible for carrying information from the body to the brain. And the efferent spinal nerves are responsible for carrying information from the brain to the body. Now, within this elaborate system of nerves, neurons, and dendrites, there is a system that regulates the functions of the central nervous system, which lie outside its major components, such as the brain and the spinal cord. This system is known as the peripheral nervous system and is subdivided into the somatic system. This system is made up of nerves that connect to the skin, sensory. The somatic system is also that arrives via external stimuli, including hearing, touch, and sight. The structures that allow this communication to happen between the nerve and the body. Efferent means conducting outward. So just like in the spinal nerves, the afferent neurons take information from the nerves to the central nervous system, and the efferent neurons take information from the central nervous system to the muscle fibers throughout the body. The autonomic nervous system is further divided into the sympathetic nervous system and the parasympathetic nervous system. The sympathetic nervous system is vital to our survival. Have you ever heard of the fight or flight response to danger? The sympathetic nervous system revs up the body when confronted with imminent danger to either defend yourself or to escape the threat. The parasympathetic nervous system is the counterbalance to the sympathetic response to danger, whether real or imagined. Once the threat is gone, the parasympathetic brings all the systems of the body back to normal. Now at this point, you should have a basic understanding of the nervous system, but let's do a quick recap. The basic purpose of the nervous system is to coordinate all the activities of the body. It enables the body to respond and adapt to changes that occur both inside and outside the body. The two major parts to the nervous system are the central nervous system and the peripheral nervous system. The central nervous system is also divided into two major structures, the brain and the spinal cord. The brain is found within the skull or cranium, and it is made up of 6 main sections. These 6 sections are the cerebrum, cerebellum, diencephalon, the midbrain, pons, and the medulla oblongata. The other half of the central nervous system is the spinal cord. And the spinal cord is the link between the brain and the nerves and the rest of your body. The spinal cord is divided into 4 different regions: the cervical, thoracic, lumbar, and afferent and efferent spinal nerves, which merge to form the peripheral nerves. Now that we know the brain and spinal cord primarily make up the central nervous system, let's look at the peripheral nervous system. The peripheral nervous system is essentially the nervous system outside of the brain and spinal cord. The peripheral nervous system is then subdivided into 2 smaller systems called the somatic nervous system and the autonomic nervous system. So, as you can see, the nervous system is quite complex, and this is just the tip of the iceberg. Thanks for watching. Look for more videos on the nervous system at cteskills.com.
Okay. What do you think? Any comments?
I like how succinct it is. It's nice to get it all down in 9 minutes like that. It was really helpful.
Oh, good. I'm glad. Yeah, that was like one of the easier ones I could find. You know me, if you've been in my seminars, I like to throw biology at you, but I think it's an important component of what we do. So I'm glad you liked that one. Yeah, I liked it too. Good review.
I don't have any questions, but I agree it's a nice refresher summary.
Well, the link is on the PowerPoints. You see how complex our nervous system is? It's not just like when you hear nervous system, people don't realize, unless you're a neurologist or in medicine, something like that, but most people don't realize that our nervous system is a very, very complex thing. The central nervous system, you have the peripheral, like they talked about, but the central nervous system, there's a reason why it's called central. It is like the computer of our body. And can you imagine what happens when substances are introduced that depress or stimulate or overstimulate the central nervous system? Anybody want to guess what happens after seeing all that?
Yeah, it impacts everything else from sleep to hunger, all the systems.
Sure, it affects everything. And so your clients, if you have clients and those of you working with teenagers and kids and stuff, families, they get into things because of peer pressure or whatever, you're going to see these things. And so it's very important to know what's happening in the nervous system so that you can pinpoint, this is this, this is what this part of the brain does and all that. I want you to watch that before I talk about CNS, which is central nervous system. So I'll just say CNS now that we know what it is. But basically, there are types of substances or drugs or medications that either depress the central nervous system or hype it up or stimulate, okay? What are some of the reasons somebody would want their central nervous system depressed or slowed down?
They're suffering from anxiety and they can't turn it off.
Okay, that's one, yeah. What about pain? PTSD, yeah, pain, trauma. Help with sleep, yes. If you watch TV from some of the old time shows, like in the 50s and stuff, in the 60s, and you went in, when you would be looking in the living room or something, all the homes had like this setup where they had alcohol, and people would come over for cocktails. It was like the big thing back then. remember watching Bewitched, and that was the first thing is they'd have cocktails before dinner. Okay. You're getting drunk before dinner. What else? What else would people do this for? You know, along the lines of PTSD and trauma, things like that. You know, I work with vets. A lot of our veterans from Vietnam, that was a huge drug addiction and alcohol issue. And so a lot of these names for these illicit drugs came from there. But it was to make the war go away. Couldn't leave because you were there for 13 months. That was your tour. But in the meantime, while you were there, one way they made the best of it was to make the war go away. You know, so think about, and I mean, it could be first responders, things like that. There's a lot of risk in those kind of populations because of the work that they do. Here are some CNS depressants that we also call them sedatives or hypnotics for obvious reasons, sedating. And if you remember, if you were at the last one, I talk about anxiety medications and things like Ativan, Xanax, things like that. And they are sedating. And so if you have a client, you know, you're taking care of who's on that, you want to watch for things like overt sedation. Stabilized mood, yeah. Dianetta says stabilized mood, yeah. Again, there are people who don't want to take their psych meds for bipolar disorder or mood stabilizer because of the side effects, or they run out, or they can't afford it because of insurance problems, or whatever reason, they turn to these kind of things to help them kind of, you know, feel better. Alcohol, of course, is obviously the most widely used. So, and we deal a lot with that, and it acts on those centers in the brain. Barbiturates. Barbiturates, they're actually like phenobarb, Nembutal, some of the phenobarb especially, these are prescription for seizures. They would be given for help with seizures and sleep. And these are just some of the names. Are you familiar with any of these names, anybody, or anybody got other names? And there's actually a couple websites I was looking at where they got lists of these like street names. Anybody have some other names other than what's on the screen? Interesting names. They get named based on things like color they are or the effects they have, things like that. Amytal, the blues, blue heavens. Goofballs, non-barbiturates. Quaaludes is like the most commonly known one. Goofballs, I mean, there's a lot of these I haven't even heard these names before. And so I was looking them up and there's actually a lot. These are pretty much CNS depressants, okay? So again, in the brain, it depresses those emotions, it depresses the fight or flight, just kind of to get away, okay? And alcohol over time will end up with a lot of medical problems. Liver, cirrhosis of the liver could lead to liver cancer, pancreatic problems, kidney problems, dementia. Alcohol, speaking of which, basically it's short acting. When you hear short acting, what does that tell you to expect? Remember we talked about those definitions of tolerance and dependence and addiction. It's short acting, so after a while the person needs more, and you know they withdraw from it after a while. Because only about 5% of alcohol-dependent patients are subject to serious withdrawal. Some detoxification centers do not use any kind of strategies. So interesting number. It's a small number, but it can be a significant number too, depending on who you're working with. So somebody asked, let's see, Dionetta asked about long-term effects. Again, long-term effects of something like alcohol would be, we call pancreatitis, and the pancreas is on the lower left under your rib cage, and it's the organ that helps handle like insulin. So if somebody is addicted to alcohol, they can develop what's called pancreatitis. Itis means like an inflammation. So pancreatitis, and they could develop diabetes, you know, so they would end up having to take insulin and everything. Another thing that could happen medically is with alcohol, the liver. The liver is kind of like our internal detox center, but it can only detox so much. And after a while, it just breaks down. A friend of mine, her brother just had to have an emergency liver transplant because of the alcohol. After a while, the liver stops functioning. So if you have a client or you're working with somebody or who is addicted to alcohol and they come in and you can see, you always want to look at the whites of their eyes if they're yellow. They'll have like a tinge to their skin. So that is hepatitis. That is jaundice. And so with the liver, it can develop hepatitis B or C, and that's not good. That's infectious and also very dangerous. Kills the liver. The kidneys, they filter out things, and so there's all these medical things that happen. the weight. They put on weight because alcohol is basically sugar. The more you drink, if anybody's ever gone out and had beers with friends or something like that, and after a few feel like you're bloated and stuff because of the fermentation and everything and the sugar. One of the most dangerous things that happens, I mean, they're all dangerous, but the thing that I've seen a lot of, in psych and dementia care is this thing called Wernicke-Korsakoff, which is one of the 7 types of dementia that are irreversible, that are basically fatal. It's named after, the people who discovered the plaques in the brain, but I have 2 images here. If you look at the middle of the brain image, you can see in the MRI the difference in the control on the left side and then the person on alcohol. That middle part that they talked about briefly in that video is enlarged. And so the functioning, less functioning because there's nothing there to function the tissue. Over time, more and more of the brain tissue will be basically eaten away by the alcohol effects. We have several things that happen like ammonia. All right. An ammonia level in an intoxicated person will cause them to be basically psychotic and agitated, things like that. So, we always try to take the ammonia level. If you've ever cleaned with ammonia and you've gotten a good whiff, anybody ever cleaned with ammonia and got a good whiff of it?
Yes.
What's it like?
Really strong.
It's not pleasant, is it?
Nope.
No. So imagine having that up in your brain and you can't get rid of it. What's happening is, your brain is being eaten up. I have other images. I have a lot of images that I've used with families to show them what's happening in their loved one's brain with dementia. Wernicke-Korsakoff's is a form of dementia. So that is another long-term, okay? When somebody comes into the ER intoxicated, one of the first things they get in the ER is something called a banana bag. And it's this yellow looking fluid that goes in IV. And that's because it's got potassium, which is yellow, like bananas. And it's got some vitamins because your brain needs these vitamins, the B vitamins, thiamine, niacin, folic acid. These are all in there. If you are working with somebody who's an alcoholic, yes, it's irreversible, very much so, it's fatal. If you're working with somebody, if you have a client or you work in an acute care setting and you've got somebody, on alcohol, one of their medication regimens that you will see if you do a medication reconciliation or medication history, even if you're doing an intake in your practice and they're on all these vitamins and they've got a history of alcohol, you can put the 2 together now. And hopefully you'll see why they're on these vitamins, these specific ones, because the brain needs them and the alcohol has taken that away. You all know what the DSM is? Does everybody have a DSM?
Yes.
The number 5?
Yes.
I have a friend who's got everyone from number 1 to 5, and they got thicker over time. DSM 1 was like this. You see that? And then it got thicker, and now DSM 5 is maybe that thick now. So that's how much it's evolved. Okay. All right. 6 major symptoms of Wernicke-Korsakoff. The reason I'm spending a little more time on the alcohol is because it's the most common and of something that's not illegal that people, overuse. In the old days, the ERs used to actually keep beer. And if somebody came in intoxicated, in order to prevent them from going into DTs and having like seizure or something, they would actually get an order to give them some beer to kind of like take the edge off while they detox them. So it's an interesting history of treatment.
What do they use now, Karen?
It's like a protocol. We call it a protocol. So now when somebody comes in, they're given Ativan and fluids. And again, that banana bag, the yellow thing, right away, they get blood tests. The one thing they're looking for is the blood alcohol level in the body, because that will determine how to get treated. And it'll also determine what to watch for with the head and the brain and the central nervous system. So they get the banana bag, vitamins. They get the Ativan, which helps, because we know Ativan is anti-anxiety. When you go into withdrawals, it's a lot of anxiety, and it can lead to really dangerous things like seizures and things like that. So they get the Ativan. When they get up to a detox unit or when they get up to an addiction unit, we'll use other things like tapering down on the Ativan. There's other drugs that have been used, like antabuse, things like that. So that's basically what they get. The rest of it is pretty much supportive and medical to make sure they don't have any like long-term effects or anything like that. I've had patients on my units with dementia that are alcohol related. So we watch for those kind of symptoms. Of course, they have amnesia and they're very withdrawn, but they get very agitated. So, a lot of it has to do with memory, because where is it happening? Up here, right? Well, What is one of the things the CNS does when with some of the temporal lobes and all that? What is one of the things our brain does?
Stores memory.
In memory, yeah. Memory and judgment. So if those are affected and the substances are breaking down the functions and it breaks down the structure of the brain, then you lose all these functions. One of my specialties in my therapy is I do work with dementia and elderly geriatrics and their families and stuff. So if you are working in a practice or you're working in a setting where you have people that come in that have dementia, you want to know what kind of dementia if it's possible. Sometimes they can't tell. Sometimes the only way to tell what kind of dementia somebody has is at the autopsy. But if you're familiar with, their history, you can pretty much guess that, Wernicke-Korsakoff's is they got a heavy alcohol history. Somebody was asking about maintenance treatment. Basically, this is just kind of a protocol we use. One of the things about antabuse, and it's got the two words breakdown, ant and abuse. So we know from the old Latin that ant or anti is against, abuse is what? So you see the two words. So antabuse is a medication that came out, disulfiram. And basically when the person was on it, anything with alcohol would make them sick. And so we had some compliance problems because the patients wouldn't want to take it because they wanted to drink. They got into this mindset of, well, if I only have one beer, but then they'd be on their antabuse and they'd be so sick. Little known fact or little realized fact is a person on antabuse for alcohol treatment cannot have anything with vinegar in it. Ketchup. Nobody ever tells them about ketchup. So they go out and they get burgers and fries and they throw the ketchup on there and next thing you know, they're sick and they're on antabuse. So if you get somebody that's, like that, then that's what's happening. But we want to remember that one of the things they cannot have besides alcohol is vinegar for some weird reason. Interesting, huh? Ketchup, yes, vinegar. If they do get on this medication and they do get sick, it's not fatal or anything. It's just going to be very unpleasant. But again, a lot of supportive treatment. Okay, let's go to sedatives and hypnotics. The problem we've had is that it's been abused for many years. The Valium, the Xanax, things like that, sedative addiction. It's gone from being pretty much abuse of barbiturates to being abuse of anything. Benzos, Xanax, Valium, Klonopin, anything that people think is going to calm them down. The more they use them, the more they're at risk for withdrawal symptoms if they come off them suddenly. You may have clients who are taking benzodiazepines, which are a form of sedative. They may be having problems with them because they're using them too much. One of the things that we have to do is the doctors are not supposed to give them a large supply. If they are seeing a psychiatrist and they're prescribed anxiety meds or things like that, they're not supposed to give them a large supply. Usually they'll get like 30 days as needed, but then if they run out soon, the pharmacy and the doctor know how many they're getting. And so then we start looking at, you may have a client that comes in and is angry because they can't get more Ativan, they can't get more OxyContin for their pain or Vicodin or something like that. And you start asking what happened, and they say, well, I ran out and I can't get any more. Well, but did you know that because of the history you've taken and because you know your client, that they should have had enough till the next refill? So then you start wanting to kind of explore that, things like that. And that would be a clue to you that something's happening with their medications. And I was talking about misusing the medications, and that would be one of the things, okay? The sedatives and hypnotics, while helpful for what they're supposed to be helpful for, if they're used appropriately, can lead to some really bad stuff. We've had people that have died. I mean, all these celebrities that you've heard of in the past, like Marilyn Monroe, sedatives and hypnotics, they take too many because they want to dull the pain of the psychological pain, or they want to get rid of the physical pain. Or a lot of people in the film industry were on a lot of these because of just the stress. You have to be really careful with somebody that's been using these and goes through the withdrawals and what we call the DTs and delirium tremens, which is all the shakes and stuff. We call them the DTs. The delirium happens. And so if they're on the benzos like the Xanax, Ativan, they will go through withdrawals, but it's not as bad as if they're taking the other kinds of sedatives like barbiturates, things like that. So it can be dangerous. So you want to be aware of what kind of sedatives they're on, if they're on any, and how are they using them. Another thing about CNS depression, this is just some effects, just so you know. They drink it, pills, any kind of way they can, any kind of way you're taking it. Drinking the alcohol, taking the Valium, injecting something in. There's injectable Ativan, things like that. These are just some of the things that happen, which is why they becomes a safety risk, a fall risk, at risk for seizures, things like that, as they build up the tolerance. So these were the effects. And then if somebody's going through withdrawals from these things, alcohol, sedatives, hypnotics, things like that, again, medically emergent, right? They will start to do the opposite of what it was supposed to do, that paradoxical thing. So they'll get anxiety, they'll get really restless because they're coming off of it. And these kind of things will happen. Again, delirium tremens. So delirium is delirious. And then the tremens is the word for tremor. So they start to, look like they're having alcohol withdrawals, which they probably are. Delirium tremens is very common with alcohol withdrawal. And so that is a medical emergency. They could have seizures. And so if you remember, I was talking about if somebody's in the ER, if you have a client that comes in for therapy and they're clearly intoxicated, that could be a medical emergency. First of all, you can't work with them anyway that day, but they really need to be admitted if they're that intoxicated, because they have to have, their blood levels checked and they need to be medically detoxed. And you may be the one that discovers that. It's important that you know about these kind of things. Anybody heard of the term wet brain when talking about alcohol dementia? Why do you think it'd be called wet brain? What has happened to the brain? It got wet. It's all soaked up. It's like a sponge. Here are some stimulants. So we talked about depressants. Here's the stimulants. Look at all these things. Ritalin is not illegal. What do we use Ritalin for? ADD, ADHD. Caffeine? Who drinks coffee? Who drinks tea?
Me.
Who likes chocolate? Have you ever had those times when you need a soda or coffee and you go in and you order and the first thing you say is, I need caffeine? Yeah? Anybody does that?
Coffee with
caffeine.
chocolate.
Chocolate, yes. Chocolate's got a little bit of caffeine in there. Mm-hmm. Nicotine cigarettes, not illegal, but overused because the nicotine is the addictive part. The caffeine is the addictive part. Over the counter, you heard of these brands before? No-Dose? A lot of truckers use No-Dose. Vivarin, Sudafed. Okay. Sudafed and these cough medicines, several years ago, there was this big outbreak of high school students overdosing and using old medication as a drug. You drink hot chocolate, yes. And so now if you go into a store, you might notice that like in the drugstore, certain medications like Sudafed and cough medications, that have the certain medications and then they're locked up and you have to ask for them. So that's why that happened. But you see in this list, not all of these are illegal drugs. And so again, you're going to have people that come in, they're going through caffeine withdrawals. Or one of the things, if you've ever gone to a doctor and you get your blood pressure taken when you check in, one of the things they ask you is, have you had any caffeine today? Anybody get asked that?
I've never been asked that.
Really? Wow.
Me, never.
Me neither.
Why do you think they would ask that? Why would I ask that if I was your nurse?
It raises blood pressure?
Exactly. Blood pressure and pulse. If I'm going to take your vital signs, I want to know if you had any caffeine within 30 minutes, because that tells me if it's high, oh, okay, you had coffee. Let's take it in another couple minutes and see. So yeah, very important. So just remember that next time you go to the doctor and the nurse checks you in, just kind of notice if they ask you about, if you had any caffeine, things like that. Kind of like if they ask you if you've had any cold drinks before they take your temperature. Cocaine, amphetamines, things like that. These are the ones that are illicit. And so they're mixed in here, but you see these are all stimulants. Anything that stimulates the body, whether it's legal or illegal, has a potential for abuse. We all know about cocaine. Withdraw it. You come in supportive. There's not a whole lot medically you can do. And the last point, there are some medications like Effexor, which is a psych med, in the past have shown some, okay, it might work kind of thing. But with stimulants, it's a lot of supportive, medically not an emergency kind of thing, but you want to be careful. They'll feel like crap for a while they come off it. Opiates, that's like the big thing. Opiates, it's all over the world and country. I mean, that's all you hear about anymore is opiates. For that reason, one of the reasons why I wanted to do this seminar that talks about all kinds of medications, because we all know about opiates, it's the thing you see in the news, but what about everything else? We all know opiates, pain meds, morphine, heroin. Oregon, it's trying to decriminalize heroin or something like that, which is really strange.
Yeah,
But
everything. They're throwing everything. They're not criminalizing anything.
yeah, and so I saw that on the news every day, and first I shake my head, then I'm like, and then I shake my head again. I'm still trying to wrap my head around that. Anybody got any thoughts on that?
They did it in Portugal like 5 or 10 years ago, and the long-term data suggests that the abuse levels have gone down. So I don't know if there's more education happening in Portugal. That I
Oh,
don't.
really? Okay.
I think that's why they wanted to try it in Oregon, because there's a lot of people locked up over, what some people might call a victimless crime. Some people might call that. So it's just draining their system. But I don't, it's an experiment, and in the short term, I don't know how it's going to go. But in the long term, apparently in Portugal, it's going pretty well.
Interesting.
Yeah, a lot of the studies too show that the problem is that people are getting incarcerated for drug abuse, and it doesn't actually help the problem at all. And so instead of the funding going to the prison system, it's going to actual recovery programs. I don't know if that's exactly what's going on in Oregon, but I have a lot of friends in connection with the prison abolitionist movement. And part of that is getting reductions in incarcerations due to drug use.
Okay.
It is much better for the general population and for individuals to have, recovery programs instead of imprisonment where drug abuse doesn't actually get addressed.
Okay. Thank you for that, all of you who made comments, because that's a new thing to me. And so, I immediately understood some of the science behind it. But yeah, that really makes a lot of sense. So we'll see what happens, I guess. But I'm glad it's working, somewhere. I'm going to look up the research in Portugal. I was wondering while y'all were talking, simplifying it for myself. If you take the illegal out of it, sometimes it takes the challenge out of it for some people. Like, marijuana. These are just some things about opiates, things you want to look for, obvious withdrawal signs. You won't be taking vital signs, so I wouldn't really worry about it, but this is kind of what happens. If somebody comes into your office in therapy and you see their pupils are like, woo, okay, that's a sign. They start having like sweating and stuff like, they're constantly going like this to their nose, things like that. Okay, because opiates aren't just injectable, they're snorted. Some more stimulants. This is how we get it. Okay, transdermal patch with the nicotine. It's a way that people are trying to stop smoking, but it's still putting nicotine in there, but it's in lower doses over time. When we prescribe the patches to somebody, they start at a certain dose, and then over time it gradually decreases the dose to where they can be off patch and off nicotine, and that is part of the science with smoking cessation. Oh, chocolate. Well, I love chocolate. I'm going to have my chocolate. Sometimes I just need it. But you know what? There's a difference between milk chocolate and dark chocolate, too. In moderation, Moderation is the key. There are people who have like social anxiety, and they will start to use their anxiety medications too much for different situations, and they kind of get used to it. Again, withdrawals, like I said, they're going to feel like ugh for a while, but they'll get through it with support. The biggest thing we deal with is relapse therapy, therapy relapse and things like that. So does anybody work with people who have addictions and they go through the relapse, and are you recognizing some of these things here? Hopefully you are. If you work with people who have addictions, hopefully you're recognizing, or some of these things are ringing bells in your head like, oh, you know what, that client that came in, that's what's going on. Benzos. Basically, the thing about benzos is they get dependent on it. It's the Valium, it's the Xanax. That's why it's only given as needed if on an outpatient basis. You don't want to put somebody on the doctor shouldn't be putting somebody on it long term. If you have a client that's on it as needed, and they're, again, running out too soon, or they appear to be overusing it or something, then that's something to talk about. These are just what they look like, some of the names. Sometimes they'll use, an extra one because they're too panicked. This is Klonopin. Okay, the generic name for those of you that had asked before. Clonazepam is Klonopin. Alprazolam is Xanax. So again, we use different ones, benzos. You have a client who has an addiction. Hopefully, when you take their medical history, or hopefully their doctor does not put them on benzodiazepines, part of their treatment, because it's basically, they're highly addictive. They have to find something else for them. Opioids, again, these are the what we know about opioids. Opium, that's where the word comes from. Opioids, opium, poppies, the poppies. People in the military, I got any military folks out there? People in the military, we tend to stop eating things with poppy seeds because they do random drug tests. And if we call it pop hot on a random urine drug test, and they find opiates in your system and all you did was have a poppy seed muffin, you got a lot of explaining to do before they try to kick you out. I haven't had poppy seeds for a long time. I think I had my first poppy seed muffin maybe about a year ago. Street Xanax, yeah. And they snort Xanax too. It gets up in there faster. I remember catching a patient on my psych unit who was actually taking it was his Depakote, which is a mood stabilizer, and snorting it. And we caught him and we asked him, why are you snorting it? And because it gets to the brain faster. Again, that central nervous system need. So yeah, a lot of, snorted. Chinese culture, amphetamines, things like that. Another word for heroin is the horse. So I think there's like an old 70s song, Ride the White Horse. That's heroin. So a lot of musicians have, written about these things kind of secretively in their lyrics. Again, this is, what opiates are used for. We have there's a medication called naltrexone, which is Narcan. One of the things that we started to do at the VA was with the addiction program was when a veteran would be discharged from the program and they had an opiate addiction, they would be given a naltrexone injection to have with them, because if they used again, which was going to be probably most likely what to happen, then they were taught how to use this Narcan. If they ended up overdosing, or they came upon somebody that overdosed, they'd be able to use it. And so I actually wrote the competency on that for the staff. But there is something that we use. So anytime we see somebody who's overdosed on an opioid, immediately they get something called Narcan. Is anybody familiar with Narcan? Heard the term or seen it or talked about it? So opioids, people die from opioids all the time. We see all the time these celebrities that die, a lot of them from their pain meds, everything like that. Oh, yes. Timothy Leary. Who knows who Timothy Leary is? LSD back in the 60s. Okay, the magic mushrooms, things like that. This is the stuff that makes people think they could fly. This is all illicit stuff, hallucinogens. It's all illicit. Unfortunately, not everybody knows what the mushroom looks like. So there have been a lot of cases where they ate a mushroom thinking it was just a regular mushroom, but then it wasn't. So, and that referred to as shrooms. It's a specific type of mushroom. But basically about hallucinogens, they're illicit, okay? This is what happens. They go on a trip and all these kind of things start to change. If you remember Timothy Leary and back in the 60s, he was like the drug abuser. He was the hallucinogen person. And there was another gentleman, a doctor, who actually was the creator of hallucinogens back then. Yes, Stephanie, true. MDMA is, which is ecstasy, a component of ecstasy. It's being studied. It was being studied, or it still is being studied. But I know at one time, I don't know if they're still using veterans or not. There was a study that was going to be used with veterans and MDMA because the VA doesn't allow doctors to prescribe anything that is, like that. So thanks for bringing that up. Yeah. LSD, shrooms. It's got something to do with, again, the central nervous system. It's got something to do with, the response to the effects with the PTSD symptoms and things like that. So basically, yeah. True story. When I was living in LA after I got out of the Army, one of the things I did on the side was a little work in the film industry, mostly science fiction things, but I managed an actor, and it's well known. This guy is well known for it, but he did drugs in the 60s. He was actually very good friends with Timothy Leary. Somebody did an interview with Timothy Leary, and who actually said that this guy was worse than him with the LSD. Well, my friend that I managed, when he was young, he used LSD and had a bad trip, put himself on fire. He had a flashback of something, put himself on fire, burned himself. So after that, all he could get was village rolls. If any of you have ever seen like Invasion USA or anything like that, his name was Richard Lynch. And so it's out there. Everybody knows. I mean, he's gone now, but that was the reason why he had the burns. It was from a bad trip. So this is a very dangerous thing here. Okay? It's an illicit thing, but people use it. People use it like medication. They self-medicate. So when I'm talking about psychopharmacology and addiction and abuse, self-medication is what makes these things happen a lot because of different things. They can't afford regular medication. they don't have insurance, or they, they're in the addiction community and stuff. Oh, wow, it's in trial 3 right now. Stephanie says MDMA is in the trial 3 right now at Santa Cruz. I'm going to check that out. Thank you for that.
There's a book by, I can't remember his name. There's a book about psilocybin that's really interesting and about acceptance and death using psilocybin. It's the guy who wrote The Omnivore's Dilemma. I can't remember his name now, but it's really interesting about the connection with psilocybin and mental health.
Michael Pollan.
That's it, yes.
Oh, Michael Paul. Okay. Polin, right?
Pollan. I think he lives in Berkeley.
Is he the one that wrote that one about being addicted and it had all the pills on the cover? And that's not him, is it?
No, this is the one that it looks like a piece of the sky. It's like a black cover with like an opening to like a blue sky with white clouds. Just the use of LSD and, treating different conditions.
Oh, okay.
The microdosing that you've heard about, it seems pretty common in the Bay Area, people dealing with other disorders with microdosing of LSD.
Right. Yeah, and it's interesting, the Bay Area is where Haight-Ashbury is, and, the big drug culture and all that, things like that. How to change your mind. Okay, I'll have to check that out. Thank you. These kind of things, when we talk about psychopharmacology and addiction and drug use and substance use, there are these studies going on now that scientists are finding that, hey, maybe it's not so bad if it's helping with this, but it's a very controlled thing, as you're seeing with the trials and stuff like that. And clinical trials take a while. And so I'm glad that one is in its trial 3. It's come a long way then if it's in trial 3 already. A lot of artists, in the art world, a lot of artists, creative people, they would say that they use these things to get creative. I did my best stuff when I was on LSD or something like that. What's a church that gives shrooms in Oakland? Really? Wow. So it's out there. Again, just some treatment. You don't detox. They just basically, it's maintenance. It's getting them through the withdrawals. Again, they feel like doo-doo. Marijuana, we all know about this, right? So I don't need to spin all. We all know what marijuana is. That's cannabinols, okay? THC, and then we got the CBD, which is taken out of it. It's used for a lot of medical. I mean, there are medical marijuana card clinics out there everywhere. It basically, I've had friends with cancer who have used marijuana to increase their appetite. So marijuana is being used more and more over all these different ones, more and more for medical reasons. Unfortunately, some organizations still won't allow the doctors to prescribe it. And so what happens is their patients go outside and get it. And then guess what happens? And you have this conflict where the organization is against, calls it illicit drugs, but this person got a card from outside and they've been using this, which has been helping them. And so can you see the conflict there? Can you see the problem that's going to happen where this person is now being called an addict, but they're not, they're using it for this. And so there's, all these different kinds of things. Marijuana is Mary Jane, weed, pot, all these. There are so many derivatives coming out now with the CBD oils and things like that. There's some, I know somebody who does, who takes THC extract for her PTSD and it helps her. So brownies. When you go to a party, make sure you know what's in the brownies. That was where the food one started. But I think some of these clinics, they sell like lollipops and they sell food that actually has marijuana in it to people. Okay, inhalants. What are some of the terms inhalants? What have you heard, inhalants? You heard the term huffing?
Yes, I've heard of huffing. That's pretty popular.
Yeah. Hi, I'm originally from Brazil, and in Brazil, the street kids use shoe glue, to not feel so.
Yeah, I was just thinking of Brazil, yeah. Mm-hmm.
Yeah, the street kids, in order to suppress their hunger, they do shoe glue.
Yeah. Okay. Karina was sharing that she's originally from Brazil, and that is one of the places where you see a lot of the street kids, the young boys in the street, especially with the glue and the paint, and you see them with they got the tubes or something like that. They're huffing shoe glue. Yeah, shoe glue. Mm-hmm. Look at a couple of these. Anybody do painting? Anybody work? If you ever walk into a nail salon, there's a reason why they're wearing the mask to do nails. Have you smelled the nail salon? That is some powerful stuff. Nail polish remover, the nail polish itself. I can't stand the smell of gasoline or kerosene. So if I'm out driving or something like that, the minute I smell it, I start to get a headache. Chloroform. You know what chloroform is? Who knows what chloroform is? What is it used for?
Is it a preservative?
It's a preservative, yeah, but it also does something else, especially in the old days of medicine.
It would wake up unconscious people?
It would put conscious people to sleep.
Oh.
Yeah, they would have, sometimes surgeons would use it, just like drops. I got high on it, not on purpose. Before you go anywhere. When I was in college, I was pre-med, and one of the things I did on the side was I was helping in a lab, and they had all these preserved specimens, but they were all in chloroform. And I was in there for like 3 hours cleaning and stuff like that. I had to go to the dispensary because I was high, literally like, whoa. And that was from the chloroform. Very fast. Glue, glue, paint. Anybody that does paints, that's why people wear masks when they do certain things, because it gets in there. When you go to the dentist, does anybody get the gas, the nitrous oxide?
Do they do that?
Do they still use it?
It's still used, but it's not common. There aren't a lot of dentists in California that are licensed to use it. That is what my dentist has said.
Ah, okay. When I was younger, we discovered that I cannot have it. A couple things happened. I was just out of high school, or so. I wasn't like young, but I was in my early 20s or so. Went to the dentist, and you know how they have to like kind of tilt you this way to work on you? And they work on me, and they'd given me the nitrous oxide, and I literally got high and slid head first out of the chair. It's a big no to cross. So I'm somebody who can't have it. I'll throw up. All kinds of bad things happen. So whenever I would go to the dentist, in big red letters on my chart, I actually saw it said no gas, but that's laughing gas. But yeah, I slid out of the chair head first. I was still laughing too, and a half. True story. But yeah, inhalants, bad stuff. Again, huffing, sniffing, we've had some people share personal evidence of it. But basically, it takes away your inhibitions. I'm mentioning here, young boys in South America. Karina, you can correct me if I'm wrong, but one of the things they to earn money on the streets, they basically prostitute themselves. But because it's such a, they don't want to do it, or they're so afraid to do it, they'll go inhale things, and it takes away the inhibition so that they can do it.
This is the first I'm hearing about it. It's just heartbreaking.
Yeah, it is. Yeah, but that's one of the reasons they do it, is because to earn money, they have to give somebody sex, whether it's, it's usually men that want little boys. And to take away the consciousness of doing that, they do the huffing and stuff. Yeah, it is sad, but it's a big thing, and it's been in the news a lot and stuff. And I think Lisa Ling, she does this really good series called This Is Life. And I think one time she did an episode down there. But yeah, it's really sad. And you could tell, because they would have like this residue around their mouth and their nose. So it's if you work with families, T-boys, yes, T-boys. Mm-hmm. When I was in Saudi Arabia, I remember hearing about, again, it's long-term stuff. Anything that you put into your brain that's not supposed to be there is going to affect what's up here, as we saw in the video, and it's going to be long-term effects. What do you think long-term effects of acid are? If you put a tooth in acid or in Coca-Cola, what happens to it over time? It does, yeah. I've seen it disappear. I've actually seen a science experiment where the tooth disappeared. And so imagine the stuff that people are putting in their brain, inhaling it, injecting it, things like that, snorting it. It's affecting the brain, and it's breaking the tissue down. This is something we see a lot in athletes, right? They're not illegal, but they're also not allowed, okay? People use it to work out with. You've seen in like the Olympics, people have lost their medals because they tested positive. We've had quite a few very famous athletes. I'm sure you all are aware of many of them. Anybody remember any of them that have been kind of like barred from their sport or something for doping, they call it? Anybody come to mind in the news?
I'm blanking, but the Tour de France winner, what's his name? Lance Armstrong.
There are some football players that have, in the past. When you watch the Olympics, you really, these people are superhuman, some of them. And it's unfortunate that some of them that are really superhuman and get the medals, they end up testing positive. That's what made them superhuman. Years ago, before the fall of the Soviet Union, there were big questions in the Olympics when the East Germans would come to the Olympics, and the women looked like men, and they were winning all the medals. And turned out that they were being doped up by their, the Communist Party, so that they would win the medals. But if any of you are around my age, you remember those days of seeing the East Germans come to the Olympics, and you see the women's, and they look like men. And that's because they were, they had steroids back then. but there wasn't any real regulation. But now it's all over the place. So athletes, a lot of athletes that want to, want to excel. Are you familiar with the term roid rage? Have you heard that one?
Yeah, I've heard it.
What is roid rage, if you've heard of it?
Oh, it's aggression induced by use of steroids.
Yeah. So what does that mean it's doing to the brain?
I don't know.
It's getting up there in the central nervous system, basically stimulating things and stimulating the messages to the muscles. And so it's overstimulating. So roid rage. There are some movies I've seen where people on steroids have had roid rage. It can be very dangerous when they act out. Did you all know that some of these people that use steroids are using like horse medication steroid things? You heard about that? People are even doping up horses for races, which is horrible. I mean, it's bad enough people are doping up themselves, but when you dope up greyhounds or horses or anything, where you want to win, what are you doing to the animal? But basically, if it's helping the animal, there are some people that actually have used steroids that are used on animals in themselves. And just imagine what happens to the body after that. Boy, these are the people that are, and the people that are really, 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 really built up and they say that they did it all naturally. It's, it's a topic for discussion. Is it really all naturally or what is it? I don't know. Any thoughts on that? There's some scary looking bodybuilders out there. Anybody got any thoughts on is that really all natural or what do you think?
Is which one all natural?
Like when you see these bodybuilders that are just like massive and they say, oh, I did it all naturally without steroids, there's different thoughts on is it really? There has to be something in there, so I was just asking, anybody have thoughts on that?
If they're using steroids, then it's not natural. But I imagine some bodybuilders can achieve a good size without them. But others that don't have that genetic inclination are enhancing themselves with the steroids?
Probably, yeah.
Or other stuff. There's other stuff that they can use. Growth hormones.
What's that?
There's other stuff, human growth hormones and other.
Yeah.
They can use that, but it's not natural.
It's not natural, yeah. So, again, back to our therapy work. You have kids, young kids, that like to work out. Or you are working with a family who's got behavior problems in one of their teenagers and you discover that, they're using steroids. Maybe they're in a school sport and they're being pressured to win. And so they get a hold of, somebody that gives them steroids to use. And I don't think they test in schools, in high schools and stuff. They probably should though, because I think it's, it's more common than we think. But then you get this adolescent or this teenager comes into your practice, it's got roid rage going on and the family is telling you all these things that are happening. And they suspect or they actually know that they're using steroids. And so that's, as a therapist, what are you going to do with that? So you take that into consideration when you're making your treatment plan for somebody, especially, adolescents. And you got these. Okay, we talked about a little bit about these. Are you familiar with all these? There's the MDMA. Ketamine. Ketamine is being researched for use with depression, interestingly. And if you look at the description of what ketamine does, euphoria, well, people that are depressed, do they feel euphoric about anything? No, they don't. And so again, we're going back to some of these substances that are considered illicit, and they're starting to do the research, like with the MDMA and the marijuana and the ketamine spray. Yep. So they're doing research. So as a therapist, it would probably be a good idea if you look up some of this research that's being done so that you're informed, so that if you have somebody that is, going through a program or is taking some of these things or has, any kind of issues, but the research behind it, and we don't start automatically thinking, oh, addict, maybe they're part of the study. Fibromyalgia. Everybody know what fibromyalgia is? You see it on TV enough. But there's a depression component to it too, because of the pain, the constant pain. The Rohypnol, that is the one that, where they say when you go out with people, don't accept a drink for somebody. When you're at a party, make your own drink, because they can put that in there and then it knocks you out. And this is where you've had a lot of these cases in colleges of rape and stuff. And they've discovered that somebody put what's called a roofie or the Rohypnol in their, again, because it's a CNS depressant, like we talked about. So that's why they call these club drugs, because it's a lot of the youth and the college age it's happening. Quite a few fraternities have gotten shut down because of these kind of things. Okay, so we've talked about all these different medications and illicit drugs and non-illicit drugs and medications and substances, all these things that have the potential of being abused in some way, but are not always on the illicit drug list, as you can see. So as a therapist, it's important to know what they are and what classes they're in. We talked about in part one, we talked about the different classes of drugs so that you know what they are. But now we're going into, well, what happens if your clients, or if you start, you're somewhere working with somebody in your clients or your facility or wherever you are, and somebody's not using their medication right. Their OxyContin, their Vicodin, their Xanax, anxiety medication, they're snorting their Wellbutrin, or they're snorting their mood stabilizer, or they're using these actual, illicit street drugs. As a therapist, you want to know kind of a background of these things and what to expect and, what to know about some of the research that's out there, like some of the people are mentioning. Thank you very much, because that's very helpful. You want to read the literature. Reading the literature is not only for the medical scientists, it's for everybody. If you're, the WISR students, you've probably had your moments of, oh my gosh, it's a lot of writing and literature. But I hope you're finding that the more literature you have to look up, the more informed you're getting. And so I would encourage you to look up some of the literature on these things, that people are mentioning, and some of the resources, because you're going to find that some of these substances or these drugs or these medications that were once considered illicit, and they probably still are, but there are these trials happening where somebody has discovered that, hey, we call that a serendipitous effect. It happened with ECT, which was originally developed for schizophrenia. It turned out it treated depression. So you want to be familiar with the literature that we're talking about here because of how complex. If you notice how complex this is, when you talk about, drugs of abuse and pharmacology use and everything like that. So, as therapists, we work with addictions. And so, the more informed we are, the better off that we are helping our clients. We do use some pharmacotherapy. Again, you are not the one prescribing, but you will probably, see people in your practice who may be on some of these or who may be in recovery for some reason. And so these are just some thoughts on how we use pharmacotherapy. I've used it, in the inpatient side as a psych nurse. I've given a lot of the stuff that we use. But this interesting picture of some of the forms of opiates that people see. Can you see that picture okay? Skag, smack, dragon, tiger, horse, powder. I mean, there's all kinds of words. They're all like code words, and they come in different forms, but this is an opiate. The picture on the left, what do we know about when they're cooking? They call it cooking. People have had bad burns. You remember Richard Pryor, the comedian? He got burned badly because he was cooking, I think it was heroin in a spoon. That's how they do it. And it caught on fire. These are just a couple of maintenance therapies. Again, the naltrexone, Vivitrol. There's also another medication that I have given that is a monthly thing, kind of like those depot shots with the Aldol. And the person with the addiction, they get this monthly shot, and it's supposed to help with the cravings for addiction. And so interesting. I've only had one patient that's been on it. Naltrexone, just different therapies. Antabuse, I talked about antabuse. This is an advertisement somebody put up, but generic antabuse. This is the one that I really haven't seen it around a lot in recent years, but I remember a lot of the veterans in our program want antabuse, and this is the one where they can't have alcohol because they'll get sick, but they also can't have things with vinegar in it. So again, if you're educating your client and they're they're in recovery and you're working with addictions and the word antabuse comes up, what kind of light bulb goes off in your brain, hopefully, that you want to teach them about or find out about? What do you think?
Maybe some trauma related to using it.
No vinegar. Let's say I'm your client. I come in and I'm like, I'm in a recovery program, and they got me on antabuse, and I'm taking it, and I come in and you're asking me like how I'm doing, and I'm like, oh God, I feel so sick. Ugh. And then I throw up or something, and then I ask you, well, what happened? I don't know. It must have been something I ate. I had eggs for breakfast this morning, and like I always eat them, I put the ketchup on it, and then like, bing, the light bulb goes off. Again, be the informed therapist, right? Be the one that can say, there's vinegar and ketchup. Did anybody ever tell you that antabuse and vinegar don't mix? And then you start that process, so you see how that, knowing that kind of little thing there can help. Okay, no more vinegar, no more ketchup. I think that's a bomb, right? That's a bomb. Again, this is just saying again that, for substance disorders, substance use disorders, with certain ones, you don't see a lot of withdrawal symptoms. With some, you do. And so you don't have to worry about stopping them like over time, like with like some benzos where you kind of want to kind of taper them. But with these kind of drugs, usually they stop, they just stop it and then they go through withdrawals and then we support them. And then, then the rest is recovery and therapy, things like that, kind of where we come in. Somebody mentioned with a camprosate. Is there a common name for that? What I wanted to share with you mostly in this, and these are just some links for, information and help. There's a lot others. There's SAMHSA. I have clients who are on regular medications and they're misusing them. Again, now hopefully that there are problems with that. You put this part together with part one, and hopefully you will have a complete package of knowledge about psychopharmacology, but pharmacology in general, the light and the dark side of it. This is kind of the dark side of it with a little bit of light with some of the research that's coming in. So again, I encourage you to read the literature out there about some of these things that are happening and some of the things that are happening out there with the research. And again, when you work with people in your practice and they're having issues with some of these things, that hopefully that you'll be able to kind of work through in your brain. Is this an addiction? Is this an dependence? What's happening here? And you can explore things more with them and get a better outcome from your treatment plan. So that's basically what I have for you today. Again, I have a lot more resources if anybody wants to email me, offline, and I can send them to you. Does anybody have any thoughts, questions, concerns, specifics, thoughts, anything like that?
No, thank you. I don't.
I was just wondering, in a lot of these psychotropics, there's some metabolic differences in each patient. How common do the psychiatrists that you work with use genetic testing to dose the medications according to how their patients metabolize the drugs?
Interesting question. I have not heard of the use of genetic testing with medication dosing. Interesting. Is this something you heard of somewhere or research?
Yeah, it's called pharmacogenomics. Ooh. And I'll post the name of the organization. It's called StopAdverseReactions.org. StopAdR.org. And they're trying to educate physicians, public, the communities about pharmacogenomics and using the database to show the doctors that there's so many medications that are metabolized differently according to your genes.
That's very interesting. Thank you for that. I'm going to check that out. I have not heard of that.
Thank you.
But I can see it making sense. Anybody else got thoughts on that? Very interesting, but I can see how it makes sense too. Yeah. Anybody else? If you think of something afterwards, you can always email me and I'll get you the answer or the resource or whatever. This is what I have for part two. Again, I hope you got something out of it. It's a lot of information. I'm glad you liked the video. Thank you for being here, everybody. I hope I was able to share some good stuff with you guys, and I'm really glad to see you here, especially a lot of repeat folks here, which is great.